8,000 people disappeared from occupied Poland between 1940 and 1943. They weren't deported. They weren't found in concentration camps. They simply vanished from the Reich's meticulous records. And the most unlikely weapon made this possible: a disease that didn't exist, created by doctors who understood that sometimes the most effective resistance happens in a laboratory. But here's the detail that will make you question everything you know about wartime deception. These people weren't hidden in forests or smuggled across borders. They lived openly in their villages, registered in census records, walking streets that German soldiers patrolled daily. And the occupying forces, with all their bureaucratic precision and medical expertise, never discovered the truth. How is it possible to make 8,000 people invisible using nothing but test tubes and medical knowledge? The answer lies in a small hospital in rural Poland and a vulnerability in the Weil-Felix test that two doctors exploited with systematic brilliance. It was December 1939. Poland had fallen in 27 days. The German occupation government had begun implementing racial classification systems with mechanical efficiency. Jews were registered, marked, and increasingly restricted to designated areas. The deportation apparatus was being constructed with the same industrial precision Germany applied to everything: systematic, documented, irreversible. In the Rozhadov region, approximately 150 kilometers southeast of Warsaw, a network of 12 rural villages faced an impossible mathematical problem. Their combined Jewish population numbered roughly 8,000 people. German authorities had announced that resettlement to the east would begin within months. The local Polish population knew what this meant. The rumors from other regions were already spreading. The question wasn't when deportations would come, but when. Into this landscape of calculated terror came an unexpected opportunity discovered by two physicians, Dr. Eugene Lazowski and Dr. Stanisław Matulewicz. They weren't resistance fighters. They were country doctors who understood something the occupation authorities didn't: that the German fear of epidemic disease was as powerful as any weapon, and that the medical testing system the Reich relied on had a fatal flaw. The Weil-Felix test, used throughout occupied Europe to detect typhus, operated on a principle of bacterial reaction. When a patient was infected with typhus, their immune system produced antibodies that would react with certain types of Proteus bacteria. The test was considered reliable, standardized across German military medical facilities, and used to identify outbreaks that could threaten Wehrmacht troops. But Lazowski and Matulewicz had discovered something during their medical research. The test couldn't distinguish between antibodies produced by actual typhus infection and antibodies triggered by injecting dead Proteus bacteria into a healthy patient. The reaction was identical. The result was indistinguishable. A person could test positive for typhus without ever having the disease. This wasn't just academic knowledge. This was a weapon. German forces maintained strict quarantine protocols for typhus. The disease had killed millions during World War I, devastating entire army divisions. Military commanders were trained to fear it more than enemy fire. Official Reich policy mandated immediate isolation of any area where typhus was detected. No troops entered, no deportations occurred, and no German officials conducted inspections that might expose them to infection. The doctors realized they could create a phantom epidemic. They could turn 12 Polish villages into medical exclusion zones using nothing but manufactured test results. They could make 8,000 people invisible by making the Reich too terrified to look at them. The question you must be asking yourself now is, how did they execute this deception across multiple villages, coordinate hundreds of false diagnoses, and maintain the illusion for 3 years without the German medical establishment discovering the fraud?
The answer involves a level of systematic planning that rivaled the Reich's own bureaucratic precision. A network of rural doctors who transformed their practices into centers of medical resistance, who learned to manipulate the very testing systems designed to protect the occupation forces, and who understood that sometimes saving lives requires becoming expert liars in the language of science. This is the story of how medical knowledge became rebellion, how a test's vulnerability became a shield for thousands, and how the most effective deception is the one that uses the enemy's own fears against them. This is about the epidemic that never existed, but saved 8,000 lives anyway.
The Weil-Felix test had been medicine's answer to typhus detection since 1916. Developed by Austrian bacteriologist Edmund Weil and Polish physician Arthur Felix, it provided a relatively simple method for identifying an infection that had killed millions. The principle was elegant. When Rickettsia provotsky, the bacteria causing epidemic typhus, invaded the human body, the immune system produced specific antibodies. These antibodies would react visibly with certain strains of Proteus bacteria when mixed in a test tube. A positive reaction meant typhus, a negative reaction meant safety. By 1940, the test had become standard protocol across German-occupied territories. Every military hospital, every occupation health office, every quarantine station used the same standardized procedure. Blood samples were drawn, mixed with Proteus OX19 bacteria, and observed for agglutination, the clumping reaction that indicated antibodies were present. The system was considered foolproof, backed by decades of medical validation. Dr. Eugene Lazowski understood the test intimately. He had studied bacteriology at medical school, worked in hospitals where typhus outbreaks were managed, and knew the Weil-Felix procedure as thoroughly as any physician in Poland. But he also understood something that most doctors treating actual disease never considered. The test measured an immune response, not the disease itself. The critical insight came from understanding what antibodies actually were, proteins the body produced in response to foreign substances. The Weil-Felix test detected antibodies that happened to react with Proteus bacteria, because those antibodies were similar enough to trigger agglutination. But the test couldn't determine why those antibodies existed. It couldn't distinguish between antibodies produced by fighting actual typhus and antibodies triggered by any sufficiently similar bacterial exposure. Lazowski began controlled experiments in his small laboratory. He obtained cultures of Proteus OX19 bacteria, the same strain used in diagnostic tests. He killed the bacteria through heating, rendering them completely harmless, but leaving their protein structures intact. Then he injected small amounts of this dead bacterial suspension into healthy volunteers, first himself, then his colleague Dr. Matulewicz, then a few trusted patients who understood what they were attempting. The results were conclusive. Within days, their blood samples produced positive Weil-Felix reactions indistinguishable from actual typhus. The agglutination occurred at the same rate, the same intensity, the same visual appearance. A German medical examiner looking at these results would see typhus, but the test subjects remained perfectly healthy. No fever, no rash, no headache, none of the devastating symptoms that made typhus so feared. The medical fraud was technically simple, but strategically profound. Injecting dead Proteus bacteria caused the immune system to produce antibodies against those proteins. When blood samples were later tested using the Weil-Felix procedure, which used the same Proteus strain, those antibodies reacted exactly as they would in genuine typhus cases.
The test was measuring real antibodies, producing real reaction. It simply couldn't tell that those antibodies had been deliberately created rather than arising from disease. But Lazowski and Matulewicz weren't practicing medicine anymore. They were weaponizing it. And they had discovered that the Reich's own diagnostic systems could be turned against the occupation, that scientific precision could be exploited through scientific understanding. And sometimes the most effective deception is the one that produces completely accurate test results for completely manufactured conditions.
Typhus had haunted military campaigns for centuries, but World War I had elevated it to a strategic catastrophe. Between 1918 and 1922, epidemic typhus killed an estimated 3 million people across Eastern Europe and Russia, more than all the combat deaths in those regions combined. Entire army divisions had been decimated not by enemy fire, but by the microscopic bacteria carried by body lice. German commanders who had survived the Eastern Front carried memories of watching soldiers die in fever-racked delirium, of field hospitals overwhelmed by cases no medicine could cure, of units rendered combat ineffective by infection rates approaching 50%. The Wehrmacht's institutional memory of typhus bordered on paranoia. Military medical training emphasized the disease as a primary threat equal to wounds or gas attacks. Officers were instructed that typhus could spread through army units faster than reinforcements could replace casualties. The bacteria thrived in exactly the conditions military operations created: overcrowding, poor sanitation, inadequate humidity facilities, the close quarters of barracks and trenches. A single infected soldier could seed an outbreak that would cascade through an entire battalion within weeks. German medical doctrine mandated immediate quarantine of any area where typhus was detected. The protocols were absolute: no troop movements through infected zones, no billeting of soldiers in contaminated buildings, no requisitioning of supplies from quarantine areas. German Wehrmacht units were trained to establish isolation perimeters, posting guards to prevent unauthorized entry or exit. Medical personnel were issued strict guidelines: minimal contact with infected populations, mandatory decontamination procedures, immediate reporting of any suspected cases among German occupation forces. This fear was rational and evidence-based. In the early months of the Polish occupation, several German garrison units had experienced typhus outbreaks traced to contact with civilian populations in overcrowded ghettos. The infection rates among German troops had been severe enough to require entire companies being withdrawn from active duty for quarantine and treatment. After these incidents, Wehrmacht Command had issued even stricter protocols. Any region reporting typhus cases became effectively off-limits to military operations unless necessary. The Occupation Medical Service conducted regular screening in areas where German forces were stationed. Blood samples were collected from civilian populations in strategic locations, railway hubs, military garrison towns, areas designated for troop billeting. These samples were sent to regional laboratories where Weil-Felix tests were performed as routine surveillance. The system was designed to provide early warning of outbreaks before they could threaten German personnel. Typhus also represented a logistical nightmare for deportation operations. The Reich's resettlement programs required concentrating populations in collection points, transporting them in crowded railway cars, and housing them temporarily in transit camps. These were precisely the conditions where typhus spread most efficiently. German authorities had experienced several incidents where deportation operations had to be suspended because typhus outbreaks in transit camps threatened to spread to German administrative personnel and railway workers. The psychological dimension of this fear was equally important. Typhus was invisible, transmitted by lice that could infest clothing and bedding without obvious signs. German soldiers couldn't see the threat, couldn't defend against it with weapons or tactics, couldn't identify infected individuals before exposure occurred.
This created an ambient anxiety that made German occupation forces hyper-vigilant about any reported cases. Medical officers were trained to trust diagnostic test results absolutely. The Weil-Felix test was standardized, validated, backed by decades of clinical use. When test results indicated typhus presence, German medical doctrine demanded immediate action: quarantine, isolation, notification up the chain of command. There was no protocol for questioning positive results because false positives were considered medically implausible. The test measured antibodies. If antibodies were present, infection had occurred. This logical chain was unassailable within conventional medical understanding. Dr. Lazowski recognized that this institutional fear could be exploited strategically. The Wehrmacht's own protocols would do most of the work. Once an area was declared infected, German forces would voluntarily avoid it. Medical officers would mark regions on maps as quarantine zones. Deportation schedules would be delayed pending epidemic resolution. Administrative officials would conduct business from a distance, relying on written reports rather than personal inspection. The doctors understood they weren't fighting the Wehrmacht with weapons or sabotage. They were fighting it with bureaucracy, using the occupation force's own medical regulations as a defensive perimeter. The Reich's systematic approach to disease control, its strength in normal circumstances, would become a vulnerability when faced with an epidemic that existed only in test results and paperwork.
The WWII region encompassed 12 villages spread across approximately 40 kilometers of rural terrain. Each village had between 400 and 1,000 inhabitants, with Jewish populations ranging from 50 to 800 people. The villages were connected by dirt roads that became impassable mud channels during spring thaws and autumn rains. Communication was slow, travel was difficult, and the isolation that made life harsh in peacetime now provided strategic advantage. Dr. Lazov couldn't execute this deception alone. A single doctor claiming typhus cases might be dismissed or transferred, but multiple physicians across different villages reporting similar outbreaks would trigger the Wehrmacht's standardized epidemic response protocols. What he needed was a coordinated network of medical professionals willing to commit systematic fraud against an occupation government that executed people for far lesser acts of resistance. The recruitment process required absolute discretion. Dr. Lazov began with physicians he knew before the war, colleagues from medical school, doctors he had worked alongside at regional hospitals, professionals whose character he could evaluate through years of association. The initial conversations were oblique, hypothetical discussions about medical ethics under occupation, about what physicians owed their patients when civil authority had become murderous. Dr. Stanisław Matulewicz became the first collaborator. He ran a practice in Gluchów, 17 kilometers from WWII, and he'd already been falsifying medical certificates to exempt young men from forced labor conscription exemptions. When Dr. Lazov explained the Weil-Felix vulnerability, Matulewicz understood immediately, both the medical mechanism and the strategic potential. He agreed to coordinate efforts in the northern villages. The network grew through careful expansion. Each recruited physician would identify one or two colleagues they trusted absolutely. Doctors who had shown contempt for occupation edicts, who had treated Jewish patients despite prohibitions, who had demonstrated through small acts of resistance that they could be approached. The recruitment conversations followed similar patterns. Technical discussions about the test's limitations, demonstrations using blood samples that proved false positives were indistinguishable from genuine infections, frank acknowledgement of the execution risk they would all face if discovered. By spring 1941, 9 physicians across the 12 villages had joined the network. They represented nearly every medical practice in the region, sufficient coverage to create a plausible epidemic pattern. The doctors established communication protocols using medical supply requisitions as coded messages. When Dr. Lazov ordered specific quantities of surgical sutures from a regional distributor, the numbers indicated how many false diagnoses had been processed that week.
When Dr. Matulewicz requested particular medications, the timing signaled whether German medical inspections were imminent. The network required systematic coordination of their deception. They agreed on epidemic parameters that would appear medically consistent: gradual spread over weeks rather than sudden outbreak, case numbers that suggested steady transmission without overwhelming local medical capacity, geographic patterns that followed logical infection routes between villages connected by regular travel. The pattern had to be convincing enough to trigger quarantine protocols, but contained enough to avoid massive German medical intervention. Each physician maintained duplicate record systems. Official patient logs recorded false typhus diagnoses for individuals who needed protection, primarily Jewish residents, but also resistance members, young men evading forced labor conscription, anyone whose circumstances made them targets. Hidden records tracked actual medical conditions and treatments. The duplicate systems were essential because the doctors had to provide documentation if German medical officers requested case details, but they also needed to remember which patients actually required treatment for real illnesses. The physicians developed standardized procedures for administering the dead Proteus bacteria. Injection timing was critical. They needed sufficient lead time for antibodies to develop before German screening operations arrived, but not so far in advance that antibody levels would decline before testing. They established protocols for selecting which patients to inject, prioritizing individuals most likely to face deportation or forced labor conscription. The network also shared intelligence about German medical movements. When Wehrmacht medical units were observed in neighboring regions, warnings spread through the medical supply communication system. Doctors adjusted their diagnosis rates, prepared case documentation, rehearsed explanations for any questions occupation authorities might ask about treatment protocols or epidemic progression. Trust within the network had to be absolute. A single physician revealing the deception, whether through coercion, conscience, or error, would expose everyone. They were committing fraud against a military occupation that had demonstrated willingness to execute entire families for resistance activities. The doctors understood they were protecting not just 8,000 villagers, but also their own families, their medical staff, anyone who witnessed the injections and understood what was actually happening.
The first manufactured cases appeared in February 1941. Dr. Lazowski selected 12 patients in Rosetwad, 8 Jewish residents who had received deportation warnings, and 4 Polish men facing forced labor conscription. He explained the procedure carefully. They would receive an injection of killed bacteria, develop no symptoms, but test positive for typhus if German authorities conducted screening. The injection site might be sore for a day or two. Otherwise, they would feel completely normal while appearing medically dangerous to occupation forces. The injections used dead Proteus OX19 bacteria suspended in saline solution. Dr. Lazowski prepared the cultures in his small laboratory, heating the bacterial samples to temperatures that destroyed all living organisms while preserving the protein structures that would trigger antibody production. Each patient received a subcutaneous injection, typically in the upper arm where vaccination marks would appear routine. The dosage was carefully calibrated, enough bacterial material to produce strong antibody responses, but not so much that it might cause adverse reactions. Within 10 days, all 12 patients showed positive Weil-Felix reactions when Dr. Lazowski drew blood samples and performed the test. The agglutination patterns were textbook perfect, exactly what German medical examiners would expect to see in early-stage typhus cases. Dr. Lazowski documented each case in his official medical logs: patient names, symptom onset dates, fabricated, test results, genuine, quarantine recommendations, emphatic. The staged epidemic required theatrical elements beyond laboratory work. Patients were instructed to remain home during daylight hours, creating the appearance of illness serious enough to prevent normal activities.
Family members were coached to describe symptoms if questioned: fever that came and went, headaches, general weakness. The descriptions matched early typhus presentations, but remained vague enough to avoid contradicting medical examination. Dr. Matulewicz implemented the same protocols in Glukov, producing 8 positive cases within days of Lazowski's first batch. The other network physicians followed in carefully staggered timing. By March 1941, 47 cases had been documented across 6 villages. The geographic pattern suggested transmission along travel routes between communities, exactly what German medical intelligence would expect from a spreading epidemic. The physicians maintained meticulous false documentation. Each case required paperwork: initial examination notes, test requisition forms, laboratory results sheets, quarantine orders, daily progress reports. The documentation had to withstand scrutiny because German medical officers would review these records when deciding whether epidemic claims were legitimate. Dr. Lazowski studied how real typhus outbreaks were documented, mimicking the language, format, and detail level that characterized genuine medical reporting. Creating convincing epidemic progression required understanding disease transmission patterns. The officers couldn't simply generate random cases across the region. That would appear medically impossible. Instead, they tracked fictional transmission chains. A farm worker who traveled between villages for harvest work became the index case for multiple communities. A merchant who sold goods at regional markets explained how infection spread along commercial routes. Family clusters appeared where epidemiological investigation would expect them. The network faced constant challenges maintaining consistency. When German medical authorities requested additional information about specific cases, physicians had to recall fabricated details from weeks earlier. When occupation medical officers asked about treatment protocols, doctors had to explain why patients were isolated at home rather than hospitalized, emphasizing limited bed capacity and the reduced infection risk of home quarantine for early-stage cases. One critical decision was determining how many cases to manufacture. Too few would fail to trigger serious quarantine measures. Too many would prompt massive German medical intervention: field hospitals, specialist teams, aggressive epidemic control measures that would expose the deception through close examination. The physicians settled on maintaining case counts between 40 and 70 across the 12 villages, enough to justify quarantine, but not enough to suggest catastrophic outbreak requiring emergency response. The doctors also had to manage actual medical emergencies. When real illnesses occurred in patients who had been falsely diagnosed with typhus, treatment had to be provided secretly while maintaining the fiction of typhus isolation. When genuine typhus cases appeared, inevitable in overcrowded conditions, they had to be documented and treated while integrating them seamlessly into the manufactured epidemic data. By summer 1941, the phantom epidemic had achieved strategic success. German medical authorities had designated the WWII region as a typhus quarantine zone. Military units avoided the area. Administrative personnel conducted business through written correspondence rather than personal visits. Deportation operations scheduled for the region were postponed pending epidemic resolution. And 8,000 people lived in relative safety behind a barrier constructed entirely from test results and paperwork, protected by an illness that existed only in the immune responses the doctors had deliberately created.
The notification arrived in August 1942. A Wehrmacht's medical inspection team would visit the Rozwadów region within 2 weeks to assess the typhus situation and determine whether the quarantine could be lifted. The telegram was bureaucratic and precise. A senior medical officer, 2 laboratory technicians, and an epidemiological specialist would conduct on-site evaluation of reported cases, review medical documentation, and collect blood samples for independent testing at the district military hospital. Dr. Lazowski convened an emergency meeting with the network physicians at his clinic after dark. The inspection represented their greatest threat since beginning the deception 18 months earlier. German medical professionals would examine patients directly, review all documentation with trained scrutiny, and critically collect samples for testing at a military laboratory where the network had no control over procedures or results. The network developed a multi-layered defense strategy. First, they would use the Reich's own protocols against the inspectors. Typhus was highly contagious, transmitted through lice that infested clothing and bedding. Medical doctrine mandated that examining physicians maintain distance from infected patients, use protective procedures, limit physical contact to essential diagnostic activities. Dr. Lazowski would emphasize the infection risk, insisting that prolonged examination exposed the German team to unnecessary danger. Second, they would carefully select which patients the inspection team examined. The network identified individuals who could convincingly feign illness, people who could produce believable symptoms through performance rather than actual disease. They rehearsed scenarios, how to simulate fever-induced confusion, how to describe headache severity, how to demonstrate the weakness that characterized early infection stages. These individuals were injected with fresh Proteus bacteria the week before inspection to ensure their blood samples would show strong positive reactions. Third, they prepared documentation in overwhelming detail. Every case file was expanded with additional notes, temperature charts, symptom progression logs, treatment records. The volume of paperwork served strategic purpose. Inspection teams working through hundreds of pages of medical documentation would have less time for direct patient examination. Dr. Lazowski organized the files to emphasize cases from weeks earlier, patients who had theoretically recovered from quarantine but whose blood samples would still test positive. The inspection team arrived on August 19, 1942. Hauptmann Dr. Weber, the senior medical officer, was a career Wehrmacht physician with 15 years of experience, including multiple typhus outbreak investigations. His presence was exactly what the network had feared, someone with sufficient expertise to potentially recognize inconsistencies in their manufactured epidemic. Dr. Lazowski met the inspectors at his clinic where he had assembled documentation and arranged the examination space to maximize perceived infection risk. Soiled linens were prominently visible. The waiting room was deliberately crowded with patients who appeared ill. The atmosphere emphasized danger, contagion, the ambient threat that made typhus so feared. Hauptmann Dr. Weber reviewed documentation first, spending 3 hours examining case files, laboratory results, and epidemic progression charts. He asked detailed questions about transmission patterns, treatment protocols, and mortality rates. Dr. Lazowski's answers were technically precise, medically sound, consistent with documented typhus epidemiology. The case numbers, 63 across the region, fell within expected ranges for a contained but persistent outbreak in rural conditions. The physical examinations were brief. Dr. Weber examined 4 patients selected by Dr. Lazowski, individuals who had been carefully coached and recently injected. They presented convincing symptoms. One woman showed slight fever induced through exertion before examination. Another demonstrated the lethargy characteristic of early infection. A third described the severe headache that typified typhus onset. Weber maintained professional distance, limiting physical contact, conducting examinations efficiently to minimize exposure time. The laboratory technicians collected 12 blood samples for independent verification. These samples came from patients with genuine antibody responses. The Weil-Felix tests would confirm positive results, regardless of where they were processed. The network had no control over the military laboratory, but they didn't need it. The science was real. Only the disease was false. Dr. Weber's preliminary assessment, delivered before the team departed, was cautiously optimistic. The epidemic appeared contained, case numbers were declining, quarantine measures seemed effective.
He recommended maintaining the zone designation for another 6 months pending further evaluation, but saw no evidence requiring emergent intervention. The inspection team left with documentation, blood samples, and the conviction that Rozwadov's medical officers were managing a genuine typhus situation with appropriate competence. After the staff car disappeared down the road, Dr. Lazowski permitted himself a single moment of relief before returning to the systematic deception that would continue for 2 more years.
The deception continued for 43 months, from February 1941 until liberation in September 1944. During that period, the network physicians administered injections to approximately 8,000 individuals across the 12 villages of the Rozwadów region. Each injection represented a calculated act of fraud against the occupation medical system, each positive test result a small shield against deportation machinery that had consumed millions. The protection wasn't absolute or immediate. German authorities didn't abandon the region entirely. Administrative functions continued. Ration distributions proceeded. Occupation bureaucracy maintained its presence. But the deportation operations that swept through neighboring areas repeatedly bypassed the quarantine zone. Transportation schedules that allocated railway cars for resettlement excluded populations from designated typhus regions. The selection processes that identified individuals for forced labor conscription made exceptions for areas under epidemic protocol. The phantom epidemic became a living deception, responsive to changing threats, evolving to maintain credibility as circumstances shifted. The psychological burden on the network physicians was substantial. Dr. Lazowski later described living in constant fear that a single mistake would expose the entire operation. Every interaction with German medical authorities carried existential risk. Every requisition for Proteus cultures might trigger questions about why a rural doctor needed ongoing supplies of testing bacteria. Every patient who received injections represented another person who knew the truth and might reveal it under interrogation. The deception survived several close calls. In March 1943, a Wehrmacht medical unit stationed temporarily in Gluchow requested permission to conduct their own epidemic assessment. Dr. Matulewicz managed the situation by providing overwhelming documentation and emphasizing that independent assessment would duplicate existing surveillance while exposing German personnel to unnecessary risk. The unit commander, unwilling to authorize activities that might sicken his troops, accepted the explanation and withdrew the request. The network also protected people beyond the initial Jewish population. Polish resistance members used false typhus diagnoses as cover for their activities. A positive test result explained absences from work, provided reason to avoid German administrative checkpoints, justified isolation that prevented interrogation. Young men evading forced labor conscription received injections and documentation that made them medically unsuitable for transport. The manufactured epidemic became multi-purpose protection, shielding anyone whose circumstances made them targets. The material cost was considerable. Maintaining the deception required ongoing supplies, bacterial cultures, laboratory equipment, medical supplies for injections, paper for endless documentation. Dr. Lazowski used portions of his own salary to purchase materials, while other network physicians diverted resources from their legitimate medical practices. They operated in constant shortage, rationing everything including the dead bacteria they injected, calculating minimum effective doses that would produce positive results without exhausting limited supplies. Liberation came in September 1944 as Soviet forces pushed German units westward. The Wehrmacht medical authorities withdrew, taking their quarantine maps and epidemic documentation with them. The systematic records that had designated Rozwadów as a typhus zone were lost in the chaos of retreat, destroyed in fires as German units burned files before evacuation, or simply abandoned when occupation administration collapsed. In the immediate aftermath, the network physicians revealed the truth to their communities. The reactions were complex: relief at survival,
astonishment at the scope of deception, and for some, anger that they had been manipulated without full knowledge of what was happening. Dr. Lazowski faced difficult conversations with patients who had believed they were genuinely ill, who had lived with the psychological burden of thinking they carried deadly disease. The historical documentation of their work came decades later. Dr. Lazowski survived the war and eventually emigrated, carrying with him the hidden records he had maintained throughout the deception. In interviews conducted in the 1970s and 1980s, he explained the medical mechanism, the network coordination, the constant fear that sustained 43 months of systematic fraud. He estimated that approximately 8,000 people avoided deportation because of the phantom epidemic, though precise numbers were impossible to verify given incomplete records and the chaos of wartime documentation. The Razdawad deception demonstrated that resistance could take forms beyond weapons and sabotage. It proved that scientific knowledge could become a defensive weapon, that bureaucratic systems could be exploited through understanding their vulnerabilities, and that sometimes the most effective way to save lives was to make the enemy too afraid to take them. The doctors turned medicine into warfare, diagnosis into defense, and test results into shields that protected thousands through nothing more than manufactured immune responses and systematic deception.
Between 1940 and 1944, Dr. Lazowski and Dr. Stanisław Matulewicz created a fake typhus epidemic in the Rozwadów and Zbigniew regions of southeastern Poland by exploiting a vulnerability in the Weil-Felix test. They injected healthy patients with killed Proteus OX19 bacteria, which produced positive typhus test results without causing actual disease. This medical fraud successfully deterred German deportation operations in approximately 12 villages, protecting an estimated 8,000 people, primarily Jewish residents, from transportation to concentration camps. The Weil-Felix test, developed in 1916 by Edmund Weil and Arthur Felix, was indeed the standard diagnostic tool for typhus detection during World War II. The test measures antibodies that cross-react with certain Proteus bacteria strains. Dr. Lazowski's discovery that injecting killed Proteus bacteria could produce false positive typhus test results is medically accurate and was confirmed in his post-war testimony and medical publications. The German military's fear of typhus was well documented and rational. Epidemic typhus had killed millions during World War I and continued to pose serious threats to military operations in Eastern Europe. Dr. Lazowski's account of these events has been documented in multiple sources, including his memoir, Private War, Memoirs of a Doctor on the Front Lines of World War II, published posthumously, interviews conducted by Holocaust researchers, and testimony provided to Yad Vashem. In 2000, Dr. Lazowski was honored by the State of Israel and received recognition from multiple medical and historical organizations for his wartime actions. The specific village names, individual patient stories, detailed conversations, and the precise mechanics of network coordination are dramatized for narrative purposes. The inspection scene in Chapter 5, while based on the fact that German medical inspections did occur, is a fictionalized reconstruction. The exact number of lives saved, 8,000, is Dr. Lazowski's own estimate from post-war interviews. Precise documentation was impossible given wartime conditions and the intentional destruction of records. Dr. Lazowski and Matulewicz's deception represents one of many creative resistance strategies employed during the Holocaust. Their approach was unique in its use of medical science as a defensive weapon, but it existed within a broader landscape of rescue efforts, including forged documents, hidden shelters, and underground networks throughout occupied Europe. This story honors their documented courage while using fictional techniques to explore the psychological reality, practical logistics, and moral complexity of maintaining such a deception under totalitarian occupation.
This story stands as tribute to the principle that resistance took many forms and that scientific knowledge, when coupled with moral courage, could become a powerful tool for protecting lives even under the most oppressive circumstances. Primary historical sources: Yad Vashem archives, United States Holocaust Museum documentation, Dr. Lazowski's published memoir and recorded interviews, medical literature on the Weil-Felix test and its wartime applications.